Hi, my name is Jasmine. I'm representing the pharmacy team. Patient Margaret Bush is a 55-year-old white female with end-stage renal disease from hypertension, type 2 diabetes. She has received a deceased donor kidney transplant 8 days ago and is presenting for her first post-transplant follow-up appointment. Her donor background is a mid-40s-year-old man that died secondary to stroke with terminal serum creatinine of 0.9. MB's KDPI is 35%. All cultures show no growth, and there's a 0 to 1 to 1 immunologic mismatch. Panel reactive antibodies are class 1 52% and class 2 99%. Her cold ischemia time is 18 hours and 32 minutes. Her revascularization time is 40 minutes, and she has received thymoglobulin 1.5 milligrams per kilogram times 4 doses for induction. Her past medical history includes hypertension for 21 years, type 2 diabetes for 14 years, end-stage renal disease as of June 2014, and a drug-eluting stent as of August of 2016. Her allergies include amoxicillin and codeine, with reactions of nausea and passing out, respectively. MB occasionally drinks alcohol, is a former smoker, and has no history of illicit drug use, and her vaccines are up to date. Her current medications include tacrolimus, mycophenolate mofetil, prednisone, valganciclovir, Bactrim, nystatin rinse, famotidine, carvedilol, atorvastatin, clopidogrel, aspirin, insulin glargine, and insulin aspart. Vitals include a blood pressure of 158/78, a heart rate of 75, a pain score of 3 out of 10. She is 65 inches tall. She weighs 98.9 kilograms, and her creatinine clearance is 74 milliliters per minute. Her labs includes a serum creatinine of 1, a blood glucose level of 138, and a tacrolimus level of 6.4. MB is currently taking tacrolimus, mycophenolate, and prednisone for immunosuppression. MB's tacrolimus level as of today was 6.4 nanograms per milliliter, and the goal is between 7 to 10. MB is taking Valcyte, Bactrim, and a nystatin rinse to prevent opportunistic infections. Consider altering immunosuppression regimen due to the patient's blood pressure and blood glucose. Goal of therapy is to prevent graft rejection while minimizing MB's risk for opportunistic infections. Recommend patient continues tacrolimus and mycophenolate for immunosuppression. Discontinue famotidine as patient has no indication and is shown to alter absorption in immunosuppressants, and educate the importance of taking immunosuppressants on an empty stomach. Alter Bactrim dose to 800/160 for a UTI prophylaxis, and increase the dose of Valcyte for 900 milligrams daily. Discontinue the patient's prednisone, as KDIGO guidelines suggest discontinuation of corticosteroids after the first week of transplantation, with a low immunologic risk and due to the hypertension, GI, and hyperglycemia adverse events. Advise the patient to follow up in 3 days to obtain a tacrolimus level and monitor kidney functions such as BUN, serum creatinine, and electrolytes. BM has a past medical history of hypertension and diabetes. They present today with a blood pressure of 158/78 and a fasting blood glucose of 138, which is above the blood pressure goal of 130/80 according to KDIGO, and above the fasting blood glucose level of less than 120 according to ADA guidelines. MBA is currently taking carvedilol for hypertension and basal and bolus insulin for diabetes. MB reports having diarrhea since she started taking the immunosuppressants. Consider alterations to current therapy to ensure chronic disease states are managed. Goal is to control MB's chronic disease states and reduce adverse events, while continuing her on adequate immunosuppression therapy. Carvedilol and prednisone contribute to the glucose intolerance. Discontinue carvedilol and initiate nifedipine 30 milligrams daily, as they are first choice for agent for CNI-induced hypertension, according to the KDIGO guidelines. Advise patient to monitor blood glucose at home 3 times daily, in the morning, after a meal, and at bedtime. Continue to monitor patient's blood pressure and blood glucose as she reports to the clinic for her tacrolimus monitoring. Recommend patient to take loperamide over the counter if her diarrhea does not improve with discontinuation of prednisone and famotidine. Advise the patient to follow up with her PCP for an A1C and continuous blood pressure monitoring. Patient's husband stated he is unaware if his wife takes medications with or without food. Educate the patient the importance of taking immunosuppressants without food and to be adherent to their schedule. Educate the patient that immunosuppression therapy will continue indefinitely to help prevent organ rejection and that opportunistic infection prophylaxis will continue for approximately 6 months to prevent infection while in an immunocompromised state. Educate the patient of the importance of contacting the doctor before starting or stopping any medication therapy, including over-the-counters and herbals, as this may lead to transplant complications. Thank you.